Uganda Extra.
Thank you for being with us on UBC TV. We do really appreciate. Welcome to Good Morning Uganda Extra, where we now also have guests in studios and discuss issues of national concern. Now, this morning, we are going to be looking at cancer treatment and palliative care. We're going to be specifically handling a disease known as cancer, where when you look at global statistics, and when we come to Africa, in particular, when we come to Uganda, we're seeing more cases of cancer than ever before. And we are seeing the world waking up to fight this disease, of which issues of health, anyone at any time, you can fall prey to any form of illness. Now, cancer is a threat to many people, including myself. But well, sometimes, maybe because we know little about it. But I'm delighted to have people who are so much into cancer treatment, palliative care, and when we talk about that, we are discussing, or we are referring to the Uganda Cancer Institute that is doing a tremendous work as far as treatment and care of cancer patients in our country. And joining me on set is Dr. Benjamin Mwesije, who is a pharmacist and head research at the Uganda Cancer Institute. Doctor, you're most welcome.
Thank you for having me.
And
good morning, everyone.
Next to me is Joyce Zarango, Capacity Building Manager, Palliative Care Association of Uganda. You're most welcome.
Thank you so much.
To begin with, Doctor, when we talk about cancer, what is cancer?
Thank you, moderator. Cancer is a disease that, in a nutshell, comprises about 100 diseases, but this leads to a malfunction of body cells. Body cells have got their natural way in which they function, but if a body cell deviates from its normal function of growth and division, then that may lead to a swelling in the body that may not cause pain necessarily, or that causes pain. And this is where we categorize cancer or tumors, that cells gathered together to form a swelling that we call tumors, as benign, that can be removed and there's no effect, but also as malignant, that can be removed but also causes other deformities within the body. In a nutshell, that's how I can describe cancer.
Okay, still, then when we talk about the Uganda Cancer Institute, briefly tell us more about this.
So the Cancer Institute is a government-established institution that was established by an Act of Parliament in 2016, and whose main function is to manage all cancer-related conditions and palliative care as well. Its foundation is based far back in 1967, when it started as a small research center in collaboration with the National Cancer Institute in the US, but that metamorphosed into what we call the Uganda Cancer Institute today, where they are not only doing research, they are doing care and rehabilitation of patients who are suffering with cancer.
Okay, now Joyce here comes from palliative care, a word that is now so common when we talk about cancer. It almost moves in, they move in tandem. Now, what does the Palliative Care Association of Uganda do, and what is palliative care?
Okay, thank you so much. Palliative care is active holistic care for individuals across all ages that are faced with life-threatening illnesses. And as the Palliative Care Association of Uganda, we have a vision that says palliative care for all in Uganda, and we work closely with the Ministry of Health through 5 focus areas to ensure that we accelerate the integration of palliative care into Uganda's healthcare system. We do this in 5 focus areas, and one is capacity building. And basically this is to see that we strengthen the capacity of health workers through training, scholarships, and mentorship to provide this unique service. Remember, I said it's a holistic service that not only looks at treatment where Dr. Benjamin is, it goes beyond to say, what is the psychosocial care of this patient and their families? What is the spirituality? Sometimes the pain is not about the cancer I have. The pain is about my wife who is away from me when I have prostate cancer. So it's all that is entailed. So we build capacity. We do advocacy and awareness creation from the national level to the lower level, which is community, to ensure that palliative care is integrated in all the policies, in all the services in our country. Then we do research and information, which is very basic and key to inform our country. For example, as a nation, Uganda, from the last research that was done by the Lancet Commission, it shows that only 11% of our population are receiving palliative care, and it's only provided by 4.8, which is a very small margin, meaning we really need to have a big thing to do, and research is very key. Then we do governance and resource, governance and support function, where we work closely with the hospices. The entire country has only 13 hospices, and these are in the different regions of the country, and we work with the public institutions or hospitals where we have palliative care units. And lastly is resource mobilization and sustainability to ensure that these entities are supported. So we go beyond to work out with partners to ensure that we get some funding for palliative care services in the country.
Okay. Now, Joyce, while she was telling us more about palliative care, she brought in a bit of statistics.
Yes.
Now, doctor, this takes me to look at the status of cancer in Uganda. For over years, we've been hearing it is, well, the disease burden is increasing and all that. But since you're here, how big is this problem?
It's a very big problem, and it's a very big problem indeed. At the moment, our recent statistics shows that we have about 34,000, over 34,000 cases, and about 21 deaths annually. And
now that is 21,000,
21, we have 34,000, over 34,000 cases, new cases annually, and over 21,000 deaths annually. So that gives you the magnitude of the number of people we lose, the new cases we get, but also the number of people we lose annually. If we can convert it into economic value, that means a lot. That on the side, we have about 5.7% annual incremental rate of incidences. In other words, if you look at 10,000 people, 5.7% of those, if you look at 100,000 people, 5.7% of those will be the new cases that are recorded annually. Unfortunately, it's about 20% of these cases that we get at the Cancer Institute.
Oh, no.
And the reason could be because of proximity. We are centrally located in the city, and most of the population at the countryside, they may not be accessing cancer services. It's the reason in the Act is well established that the UCI will be responsible, in Section 4, will be responsible for establishing regional centers. And as I'm speaking now, we have regional center in Mbarara functional. We have one in Gulu, which is due to open very soon. We have one in Bali, which is due to open soon. And then we're going to have another one in Arua to increase accessibility of cancer services to the Ugandan population. Well,
statistics are not that very interesting when you look at over 21 death registered, 21,000 death registered every year. And then we look at new cases, over 34,000 cases are registered every year of cancer in our country. Well, it is a very big problem. Now, a quick one. I've asked this to a number of experts in the field, and none has given me a conclusive answer. I've interacted with so many doctors on what causes cancer.
There is no definite.
So you're doing the same?
There's no definite cause for cancer. And the reason why that is the case, because naturally, God has blessed us with an immune system that is able to fight all diseases, including cancer. Unfortunately, there are what we call predisposing factors. Some of these are difficult to remove them from our system. For instance, genetics. If you have a gene that is linked to a cancer, it's very likely that in your lineage or in your lifetime, you will get cancer. There is one person who said, you may overcome all accidents on the road, all diseases until when you are 70, and when you are 71, you get a cancer. That is as a result of age. So we could say age-related cancers. But what about a child who is born with it? Yeah. Because out of those numbers I've given you, about 10 to 20% are children. And some of them, or most of them, die before the age of 10. For various reasons. However, cancer in children is curable. Actually, comparatively to men or women who are adults, in children, cancer is curable. We have very many cure rates in children. And could be an emphasis of why we should establish pediatric oncology services, because we see a future in that. That doesn't mean to say we should neglect the adult.
Yes.
For the adults, once detected early, it's also treatable. So we need to have a comprehensive approach. The key message is early detection.
Okay.
If we get cancer early, we treat it, chances of survival are high.
Now there, the only problem is Ugandans, majority of us only go to hospitals when we are not feeling fine, when we are sick. But marching into a hospital or health facilities for a medical checkup is something not common with us. And anyone will tell you, are you sick? No. Then why are you going there? I'm going for a medical checkup. And they'll look at you like, this one has made man of late that he even feels he should see a doctor when not necessary. But also this takes me to palliative care now having been defined well by Joyce. Who needs it and where does one get palliative care?
Thank you. So who needs palliative care? I'll say we all need palliative care. But when we say life-threatening illnesses, we look at illnesses like cancer, we look at sickle cell, we look at HIV, and all the other life-threatening illnesses, diabetes in there. So before, when we used to talk about palliative care, everyone would just say palliative care, attach it to only cancer. But it's beyond cancer. It goes to the older persons who are unable to do everything for themselves. And as we age, we know our systems deteriorate. So palliative care comes in to play a big role. And palliative care is not end of life. I'll emphasize this because when you say palliative care, people think about the dying. People think about, oh, end of life, someone who is going to die. Palliative care starts from diagnosis. And we say it also encompasses prevention. Like we mentioned that people don't go to hospital until they are sick. We are saying as we go to communities to create awareness, we say go for screening. He has mentioned that childhood cancers cure, but I would say even cervical cancer, once detected early and managed properly, we've seen success stories. Breast cancer, we've seen people go on. So early detection is part of palliative care. Then we go through the course of treatment until we know that it is supportive treatment and palliation, where we just provide pain control and management of symptoms from homes, from hospitals, from outreaches, to ensure that patients and their families are comfortable. So palliative care does not look at a patient alone. It encompasses who is with this patient, who is the carer. So it looks at the patient, the family, the community, to give a holistic approach that improves the quality of life of this person. Yeah.
Well, with palliative care well addressed and why we should ensure that these facilities are really available, we also now look at the treatment doctor. You know, how available. Like one thing I've noticed with a few cancer patients I've seen, they're always in pain. Real pain. and you can even see it and feel it when you're not the patient. So how are we standing in terms of treatment and availability of medicines?
Thank you, moderator. I want to categorically state clear that from the establishment of the Uganda Institute as an autonomous entity, we have a budget that is fully funded by the government of Uganda through the Ministry of Finance. This budget for drugs has been increasing over time from 2010, before the autonomous, up to today. And that everyone who comes to the Cancer Institute comes and receives medicine at no cost. Rarely do you find patients looking for medicines from out of pocket, unless if those medicines are high-end medicines, what we would call immunotherapies that we haven't established, and because of cost. Our budget is slightly above 10 billion now for drugs and sundries and laboratory reagents, and it has been increasing from about 1.5 last 10 years to about over 10 billions at the moment. And we do purchase them from reputable sources, and these are the drugs you can find everywhere in the world. And so, as far as I know, the patients who come to the Cancer Institute, they get free treatment at no cost, unless if it is a high-end medicine that is not in our essential drug list, that will ask patients to buy out of pocket. So, it's the reason why we're holding live information or broadcast information in media, to say that unless if it's not available at the pharmacy, in the hospital, at the UCI, that's when we can ask a patient to buy. But most times, patients get all their medicines at the UCI pharmacy at no cost.
And I must say yes, because I've had a number of patients and they can testify to that. I don't know how you're doing away with issues of corruption and doctors saying go to this pharmacy because for you in the medical fraternity, there has been that belief, most of free things where they are, that things are not as smooth as they should be. You say, I need this medicine, I'm told treatment is free here, but then somehow there are middlemen, there are this and that. But I've not heard so much of those stories at the Cancer
We have tried
Institute.
to streamline service at the UCI. The first thing is to see the doctor and get a prescription. The next thing is to walk to the pharmacy, and it is a direct line. You don't have to know anyone there for you to access this. Then the second is that constant information flow to the people who come, to the staff who are there, but also looking at the type of patients we serve. They are vulnerable population. You really be a killer if you really ask that person to pay an extra coin. I know that even if we increase our budget to about 20 billion or 50 billion, it may still not be enough looking at the number of patients that we receive every day. And I'm very certain that government will look at it properly when we expand to these all entities that are coming up, like in Gulu, in Bale. But I know, again, with the leadership that we have, they will have to look into it and see if they can increase that budget to meet the population demand. The medicines, again, are free. They are from reputable sources, and they are available at the pharmacy. If it's not there, of course, we tell you it's not there. But when it comes, again, we tell you it has come for some reason. Of course, there are delays of procurement that can come in here and there, but doesn't mean that that warrants a patient to pull money out of the pocket to buy the medicine from the UCI.
More so with cancer treatment, where it is a long time, sometimes a lifetime.
Yes, it's a lifetime, actually, I should say, because we don't treat cancer like we treat malaria for 3 days, for 2 days, or an infection for 5 days. In most cases, we have this slogan saying, once you're a cancer patient, you always remain a cancer patient, even when you don't take medicine. And this is where Zalango came in to sort of talk about palliation, because even during palliation, there are medicines required, and those will be accessed at the UCI or at designated hospitals once requested or once prescribed by the doctors.
Now, Zarango, usually when we talk about palliative care, I see doctors and nurses. Is it only for these? Who else is involved in palliative care?
Okay, thank you so much. Palliative care goes beyond. But before I mention who is involved, you really talked about an important aspect, that is pain. Pain is a very key aspect in palliative care patients or patients with life-threatening illnesses. The government of Uganda, in addition to what Dr. Benjamin has mentioned, provides medicine, and that is all liquid morphine. And this is an opioid specifically used for pain control in our country. This medicine is provided free of charge, and it is distributed to only accredited health facilities. And these are facilities accredited by the Palliative Care Association of Uganda, together with the Ministry of Health, and to ensure that patients access pain control, because their pain can be worse than anything, and they cannot respond to all these other painkillers. So you find they will need the morphine for themselves. So you go to say, who provides palliative care? This has to be trained health workers. In Uganda, nurses were not allowed to prescribe before such medicines. But in 2004, an act was put in place to allow nurses to prescribe this medicine, basically because we know we have a problem with the patient-doctor ratio. If we say it's only the doctors to prescribe, then we are leaving all our patients in agony. So to remove that agony, we have nurses prescribing pain medications to these patients. And then beyond that, like I said, pain is not only the physical pain one feels, we have psychosocial pain. And so we bring in the social workers, the counselors, to help these patients. We have spiritual pain. So we are working with spiritual leaders. Palliative care does not enforce a religion on someone. I handle you as you are. If Dr. Benjamin is a Muslim and I'm a Christian, I will not enforce Christianity on him. But I want him to be comfortable in his belief and feel the quality of life he deserves. So it brings on the religious leaders, social workers, counselors, but also the media, people like you. As you are here at this show, we are giving out information to the community to know that screening is important. So in this aspect, we need media to join us. We need the public to come in, the business entities, because there is sometimes, like Dr. Benjamin has mentioned, sometimes the medicines are not there. Is it a funding gap? As a country, how can we all of us join together? And most importantly, are the policy makers. How are the regulations for these medicines, finance, and all the other areas? So it is a collective effort of all the medical practitioners and other stakeholders to ensure that our patients get the quality of life they deserve.
Okay.
Yeah.
Well, quality of life they deserve through palliative care is something we should all join hands and help in one way or the other. Now, very important is for you, our viewers, to know that there is an upcoming conference. And this is the 4th Uganda Cancer and Palliative Care Conference that is going to be taking place on the 14th to the 15th of September, not very far from now, or from today, because we're almost saying bye-bye to August. So it is next month from the 14th to the 15th, and it's all about cancer and palliative care. But since I have these potential guests with relevant information on this, I'll begin with the doctor. This is the 4th. At least I remember the 3rd. I was available, and it was a very interesting discussion there. Now, what is there for the 4th?
Let me begin from the time when we started this collaboration between Uganda Cancer Institute and Palliative Care Association of Uganda to host conferences. The first one was in 2017, and the theme of 2017 was United Against Cancer Prevention. It was United Against Cancer. We're looking at prevention to end-of-life care. And this is where palliation comes in, as she said, from when you are diagnosed to end of life. That was in 2017. We held it at Resort, Speak Resort Munyonyo in 2017. And the second one was towards universal coverage. And here again, we're looking at cancer and palliative care. And as I mentioned, we were looking at universal coverage in terms of accessibility, availability. That's why we have these outlets of the cancer centers in regional centers. The third one that was virtual cancer and palliative care in Uganda. And this was looking at the challenges of COVID and other challenges that came in around that time. So this time we're looking at scaling up availability, accessibility, quality, and equity of cancer and palliative care. Again, this is a holistic approach looking at cancer and palliative care services, accessibility, and also the type of service that we offer. Of course, we're looking at their challenges as well. Is it adequate? Are we limited? What are the challenges? How can we overcome them? And so there are many hypotheses why we hold these conferences. And the key ones are three. One is to showcase that here we are, and this is what we offer. But two, also to meet other people who offer same services in other areas and share our challenges, share our joys, our successes, and also see how they overcome if they are ahead of us. That's why the invitation is broader, because ideally it's an international conference, not a Ugandan conference, it's an international conference. But also to see the knowledge that we acquire or have acquired over time, and see if this knowledge can turn into care and improve the quality of life of our patients who are suffering with cancer. So it is our fourth conference, and I've said the theme is scaling up availability, accessibility, quality, and equity of cancer and palliative care services.
Now, Zarango, who is supposed to attend and how do they attend?
Okay, thank you so much. Who is supposed to attend? We call upon the entire country to attend.
You don't?
Yeah, so this conference will showcase...
So there are no invitations?
We have invitations.
So attendance is by invitation?
By registration, and paying. So this
otherwise, if you call upon the entire country.
As long as they can pay. Then when we come to our limit of number, we say thank you, but we can't help you.
Okay.
But we are going to showcase plenary speakers, plenaries and workshops, abstract submissions. And how do you join this conference? Is by registration. So all this information is on our website, and that is the pikauganda.org. You get the information to know about the conference.
No,
we'll also share.
PCA.
It's PCA Uganda. Dr. Benjamin will help me write it, then we can put it on the screen. So you go to the website, you register, and when you register, you will have a prompt that asks you to pay 500,000 for nationals, 150 East African, and 300 for international delegates. Then we have 250 for students. It's very important for us to attend such conferences. One, it's avenues that helps us to engage with the public, to get to know what's happening in our country. And when we know what is happening, what can we do for that? It's not only the burden, but something has been done, like Dr. Benjamin mentioned. It's not about palliative care, end of life. Something has been done to integrate. We have now, before we had only 34 districts in around 2004 offering palliative care. Currently, we have 107 districts. It means all these facilities have something to share. And the remaining 40 districts, what can we do as a nation? So it's a conference worthy attending for all of us, policy makers, health workers, media teams. We are so grateful to UBC for the last conference. And I pray that you also engage in this conference.
Well, we are still looking at cancer treatment in Uganda and palliative care, but also letting you know that there is a conference that will be running from the 14th to the 15th of next month, which is September, at Speak Resort. Please, please, the call is come and listen, come and share experiences, come and see how far we've gone as a country as far as treatment and palliative care of persons who are having cancer. Now, doctor, she's talked about who is to attend and how they should ensure that they are part of it. But one thing, there's always this belief, and amongst the youth, they'll even tell you that, well, the fear of cancer. Someone says, getting cancer, I rather get HIV, getting cancer. You know, it's seen as the worst of diseases that can happen to someone. A message of hope.
A message of hope that I can share with all Ugandans and everyone listening to us is that early cancer detection leads to better quality of life. Early cancer detection leads to cure. What should Ugandans do? They should go for screening. Wherever you are, of any age, go for screening. You get screened, cancer is got early, cure is imminent. And that's the message I can give all Ugandans. Outside of that, we shall remain in fear, we get it and remain in fear and die in fear. But we can overcome.
You can overcome.
Yes.
Let me have your parting shot, Madam Zualango.
Thank you so much. I'll say that I'll remind you of the Palliative Care Association of Uganda. It's a membership organization. And to become part of the Palliative Care Association of Uganda, you subscribe. So you can reach out to Palliative Care Association of Uganda on using our toll-free line. That is 0800-399-100. For more information about the conference, about access to palliative care services in our country, like our theme is scaling up accessibility and availability. When you reach out to us at the Palliative Care Association of Uganda, we are able to tell where you can get the palliative care services across the country through other palliative care providers who are members of the association. Yes. And
Dr. Benjamin, as we move out of the studios, your parting shot.
I invite all Ugandans and the media fraternity to come and attend our incoming conference, because we shall share our expertise, we shall share information, and we shall educate the population about cancer and palliative care services. You are all most welcome. Don't forget the date, 14th to 15th of September 2023.
Well, I want to thank you so much, Dr. Benjamin, for the words of hope and, of course, more sensitization regarding cancer treatment in Uganda. And I want to thank you so much, Madam Zualango from the Palliative Care Association of Uganda. Thank you so much for your time and, of course, those encouragements. One thing I can say, you're not alone, dear cancer patient. There are so many of you looking at the disease burden in Uganda regarding cancer, and there is a light at the end of the tunnel. Stick to that treatment. Government of Uganda, the Uganda Cancer Institute, gives that treatment free of charge. Do not say, I'm tired of taking this medication, because that's medication that you're still alive. And to the general public, please, cancer can be treated once detected early. Let's develop a culture of going for body checkups even when you're not sick. It could be expensive, one would say, but at the end of the day, it will save your life. Have a lovely day. God bless you. See you tomorrow, God willing, for God and my country.
Thank you.
Live from UBC Studios in Kampala, this is Good Morning Uganda Extra.